Well, I got some good cases for you guys this morning. Anybody want to do this first one?
Sure. Hi there. We're looking at an excision or a punch of a sharply demarcated nodular neoplasm.
Good.
So an aggregate of basaloid cells, empty round white spaces, and larger cystic spaces that could be sweat duct lumen.
Okay, that's a possibility.
And then zooming in a little bit more.
So if you were going to look at this just at low power first, we're going to look at higher magnification. Would you favor this being benign, malignant, epithelial, non-epithelial? What kind of ideas?
So benign.
Good. Yeah.
And more, I mean, it's a little hard to tell whether it's, I would say epithelial.
Yeah, it's very likely to be epithelial or some close simulator of that. I agree.
So thinking of things that could fall under blue nodules in the deeper dermis, you could think Merkel cell, small cell carcinoma of lung. You can think.
Those are malignant, right?
Oh yeah, I mean, just like thinking about like how the purple nodule, but like other malignant
diagnosis of blue cell. Good. That's good. Yeah, you would think of neuroendocrine in there.
You can think of sweat duct neoplasms.
Like ecrine or apocrine neoplasms, that sort of thing.
You could also think, well, another malignant one would be a basal cell with like sebaceous differentiation or sebaceous neoplasms.
Okay.
Lymphomas, but again, that's malignant. Yeah.
That's good. So that's a very good differential. And of course, the very rare things, the pediatric blue cell tumors, those are kind of in the same family as neuroendocrine carcinomas in a way. Sometimes melanocytic lesions can give you kind of a basaloid morphology too. So just remember that. So let's go to higher magnification and see if we can see anything here that kind of helps us with the differential.
Yeah. So again, just noticing that there's not much atypia, so feel reassured that it's benign.
So you can see much atypia, right? So you agree that that's kind of a smudged area there. But when we look at high magnification here, these cells are really quite homogeneous and very monomorphic. They don't really have a lot of atypia to them, no mitotic figures. Okay.
Yeah, and again, appreciating, like these empty round, very circular white spaces and larger cystic spaces that could again be sweat duct lumen.
Okay, so that's that definitely could be a sweat type of lesion. What's going on here?
I don't see a pointer. Sorry, give me 1 second.
You can't see that, I guess, huh?
Yeah. So either of those is just like extravasated blood cells, or maybe they're I don't know if I see an endothelial lining on that.
Yeah, well, I think some of it's hard to tell, but it's possible that some of them actually could be in the lumen of some of these. So you're exactly right. This is the main differential diagnosis when you see this entity, when you get these small, round, very monomorphous cells. The differential includes one of the sweat gland lesions. The other thing that you have to think about is actually a glomus lesion, glomangioma, which that very, very much on a histologic basis. Let's see, and if you go back to low magnification, it's actually got some pretty large areas here that probably are blood vessels here. Usually when you see a sweat gland neoplasm, you won't have these large ectatic vascular spaces like this. So this is a simulator of a sweat gland neoplasm. It actually is a glomangioma. So more probably, if they're going to show you something like this, they might, because those can simulate one another, they probably would give you maybe a special stain of some sort. And if you were going to do a special stain to distinguish between, say, a sweat gland lesion and and say like a glomangioma like here, what would you do? Which stain would you order probably?
Yeah, I mean, it's two stains that could work for a sweat gland tumor, but also work for everything else in the skin, like an epithelial lesion. It would be P63 and P40. But if you were doing a glomus tumor, would CD34?
You could stain it for one of the actual vascular markers, but the glomus cells themselves, as you remember, are usually located like in the digits of our hands. And so when your hands get cold, they contract, the blood goes out of there and goes into your core. And then basically, so they have like actin inside the cell. So you can actually do a smooth muscle actin stain, which will highlight these cells also. So that's one thing that we often order when we really want to distinguish between, say, a Merkel and maybe a spike gland neoplasm. This one was, I thought, pretty straightforward for a variant of glomangioma, but I've seen a gazillion of these, but they can simulate one another. So that actually is something that you should keep in mind. I mean, if you just saw this area over here, you say, wow, that really looks like a sweat gland tumor in that area. So they can kind of simulate one another quite closely. So that's good that you had got that into the differential diagnosis. Those are one of the painful tumors. Of course, you can get things like spiroadenoma can be a painful tumor also. So sweat gland tumors, as well as this lesion here, can be painful. Glomangiomas are not as painful as solitary glomus tumors, and those usually see them around the fingers, underneath the fingernail often, and they're more of solid. You don't get the large sort of ectatic vascular spaces associated with that. In any event, that's what this is. So that's good that you were able to kind of recognize that differential diagnosis and realize that it's a benign lesion. And they totally removed it, obviously.
Got
Any
it.
questions about it or anything?
Yeah, thank you for walking me through it.
Yeah, it's a good case, kind of an interesting. Okay, anybody want to give this one a go?
Hi, good morning. I'll take this one.
Okay.
So we have a punch, and it's very cellular, both in the superficial and deep dermis. My initial thoughts was that it was inflammatory, but kind of in the nodular and diffuse dermatitis category.
Okay. Does your initial thought, did that sort of persist when you looked at it at other powers?
Well, I'm still not completely sure what this is. I still think it could be inflammatory, but there were a few features that made me think it could be a neoplasm as well.
Okay, there's nothing wrong with that. Actually, that's totally reasonable. So in other words, at low power, you might think one thing, and then you say, okay, and maybe it's a nodular diffuse granulomatous process. And then you say, well, let's go a little higher magnification and say, oh, wait a minute. Are those really histiocytes, when you look at it at high magnification?
Yeah, so I thought we were looking mostly at histiocytes. Some of the cells look a little foamy. But then what you're zooming into here, I kind of thought that was like some sweat kind of in that structure there.
Okay. So you say, wait a minute.
Yeah.
Maybe they're not histiocytes, maybe there's something kind of stimulating that.
Exactly. So then I was wondering if we were looking at some sort of like sweat gland neoplasm that just had this very like remarkable inflammatory reaction.
Okay, good. So why did you think they were histiocytes? Which is okay, if it was a reasonable conclusion at low power. So what made you think they were histiocytes? Why did you think they're histiocytes? Which is important because it helps you with the diagnosis actually in this case.
Yeah, because they looked epithelial and kind of like these like monomorphic blue cells with like some kind of like foamy space around it.
Yeah, the clear cells. Thought that was maybe foamy histiocyte. So what do you think? So there's a differential diagnosis of things that cause clear cytoplasm within cells. So one is lipid, obviously. What are a couple of other things that can give you a clear staining pattern with a routine H&E stain?
Like glycogen or mucin?
Yes. Glycogen, mucin. Yes, you can get mucin with inside epithelial cells sometimes, like in a mucoepidermoid carcinoma. Sometimes you get mucin actually within the cell. You get mucin within goblet cells. So yes, epithelial mucin can do it. There's a couple other things, but those are probably the most important ones. You know, like say, for example, Hansen's disease, the Lepromatous Hansen's, the lipid of the acid-fast bacteria, that's kind of like lipid. So yeah, those are the three main things. The lysosomal material within cells, say like a balloon cell nevus or balloon cell melanoma, those can look kind of the clear cells of a renal cell carcinoma. So when you see clear like this, foamy, you say, well, these are histiocytes, and you start looking, say, well, wait a minute, you know, these cells have got maybe some intercellular bridges here. They look very epithelioid. And so, yeah, and over here, you've even got maybe some possible ductal differentiation here. And possibly that may be a ductal differentiation within this lesion. So yeah, and so if this isn't lipid, what do you think it probably is here?
I'm
Of
not
your list of
sure.
3 or 4 things.
Yeah.
Well, you said it second. So what's your second choice if it's not lipid? You said glycogen.
Yeah,
Yeah.
glycogen.
And so where do you see glycogen in the skin, in epithelial structures in normal skin? Where's it located?
I'm kind of blanking right now.
Well, there's 2 main places. In the outer root sheath of a hair follicle, the clear cell area there, the triclinal different, that white sort of clear area on the outside of the follicle, that's glycogen. And then you also see it in the sweat duct, sweat gland, generally down in the lower part of the sweat gland, those little clear staining cells, that alternate with the cuboidal staining cells. They need that glycogen because obviously those cells are reabsorbing ions. So that's a relatively rapidly metabolizing cell, and anything where you need things that are kind of rapidly metabolizing, like in your brain, that uses glycogen. That area uses glycogen. The hair follicle it's the second fastest growing epithelium, or actually turning over cells in your body, or the matrix cells of your hair follicle. So they need glycogen. So when you have a metabolically active cell, they need glycogen. So sweat glands, sweat differentiation, outer root sheath of the follicle, those are the things that normally have glycogen within them. So when you see a sweat gland tumor, it's got clear staining cells in it. That's often the case. So let's go back and look. So let's say now we've decided we probably are not dealing with histiocytes, we're dealing with an epithelial lesion. Did you think this was benign or malignant?
Let's see.
Or both?
Yeah, I don't know, because I didn't really see a lot of like mitoses, but I think the overall structure of it is pretty unorganized.
Yeah, it's asymmetrical. It's pretty big. Got these irregular aggregations of varying size and shape. They've only taken a punch biopsy out of something that's obviously much larger. And there were zones in which there was some necrosis en masse. And if you kind of scroll around this, there were zones where there's some atypia and some mitoses in this lesion. Now, you can get some occasional mitoses in these lesions, but when you start seeing some of these other features that you mentioned, that asymmetry, the irregularity, the size and shape of these cells, and you start seeing some atypical mitoses like here, basically that means that it's probably becoming malignant. So I don't think the entire lesion's malignant. I think maybe if you look up here, this is probably still benign, but these sweat gland tumors, when they they become malignant, they actually undergo malignant degeneration. So they usually are benign for much of the life of their lesion, and then they become malignant over the course of time. And so that doesn't happen very frequently, but that's one of the reasons that we usually recommend re-excision of these, or we often recommend re-excision, especially if they're large. So this is what's known as a hidradenocarcinoma. And the term that's used, that you probably don't really need to know, but at least you can hear of it, is hidradenocarcinoma X hidradenoma. That means X means from. And so basically what that means is that you've got a benign lesion that has degenerated into a malignancy. And so when you start seeing these atypical cells in here, zones of necrosis and other things like that, think about a malignant version of a hidradenoma. So that's good. So basically we learned a lot there. We learned that you can see epithelial cells with clear staining cells that can simulate histiocytes. So just remember that. And then remember the various areas where you can get clear staining epithelial cells that have glycogen within their cytoplasm. Okay. How about this one? This could be on the board. Nobody wants to do this one, huh? It was pathognomonic. Surely we got somebody, some brave soul out there.
We have a UT student trying to unmute. She just needs a second.
Okay. I can't hear her yet, but let's see that. Anyway. Well, somebody want to give this one a go in the meantime?
I can take this one.
Okay.
So looks like we have a a punch, and I would call this kind of a rash more than a neoplasm.
Inflammatory process.
Yes.
So, I'm
And
not a
then-
really big fan of the word rash, personally.
Hello?
Can y'all hear me?
Yeah, we can hear you.
Oh, hey, sorry. I don't know why my computer wouldn't let me unmute.
You're good. We can hear you.
Okay.
But the word rash, I'm not a big fan of rash because it sort of is a layman's term. So I sort of think dermatologists use the word maybe eruption or inflammatory skin disease. And, this might be one lesion. So it might not really be a rash. And I think of rash, I think of measles, or something like that. Atopic dermatitis. So I think that's more of a layman's term. So I'm not going to let our dermatology residents use the word rash when we get our residency program going. So anyway, it looks like an inflammatory process. And what's the pattern of the inflammation?
It's like a superficial perivascular.
Yeah, it's superficial.
And deep a little bit.
Got a little bit deep, I agree. And it's got more density up here than down here. Now, the classic pattern of this process is kind of a more of a really classic wedge-shaped pattern, but here it's kind of like that. Okay, and none of these diseases really read the textbook. But yes, it's inflammatory, superficial, and a little bit deep. What kind of cells were in the infiltrate?
So I think primarily like lymphocytes. Oh,
They're
eosinophils.
Yeah, they're lymphs and gazillions of eos, right?
Mm-hmm.
Lots of eos. Superficial and deep, superficial and mid, kind of wedge-shaped, with a lot of eosinophils. What's what should kind of quickly as a reflex arc come to mind when you hear that pattern? It wakes you up at 3 a.m. So I got a box here that shows superficial deep, wedge-shaped infiltrate, a lot of lymphs and eosinophils.
An arthropod bite.
Good. An arthropod assault reaction, Dr. Ackman used to call it. So everybody's kind of caught on. Everybody still uses that name. So what are some kind of arthropods that could possibly cause this eruption?
Like a mosquito bite or
A bite could theoretically do that. Absolutely.
an ant bite, maybe, even though you might see more like
what do ants bites usually have in their inflammatory infiltrate?
probably neutrophils because they're kind of pussy.
Yeah, if you've ever gotten a fire ant bite, you know that after about a day or two, you start getting that firm pustule that develops. And why do they have neutrophils in their infiltrate? There's a reason.
An
ant, we talk about ant bite. It's not really an ant bite, really. It's an ant sting because it's got a sting and it injects something inside your skin when it stings you. It's used as a defense mechanism. It's saying, I don't like you, get out of here. So it's stinging you, as opposed to mosquito, which is coming and saying, hey, I love you. I want dinner. I'm hungry. So it doesn't want you to go away. It basically you know, it doesn't hurt when you get a mosquito bite, right? You don't even know it's there until you say, hey, wait a minute, something's going on here. And it usually
Yeah.
doesn't until after a couple of days later when the saliva or whatever, the juices it injects into you. So it's an anticoagulant, so it can suck your blood out. You get an allergic reaction to that. And that's why you basically get a reaction to mosquito. But the ant injects something. Do you know what it injects?
Is it like formic acid?
Yes, it's formic acid, which is a neutrophil chemotactin. So that's why it actually gives you the neutrophils and the infiltrate.
Yeah. Okay.
Well, is there another arthropod that can possibly give you this pattern? That might be sitting there looking at you right now in the field of view here?
Oh, like a scabies.
Yeah, scabies. So this is the mite of scabies.
Yeah.
Over here is another little, that might be an egg actually, it might be the actual mite though, it could be the egg, but see the burrow here? That's
yeah.
a little part of the exoskeleton of the mite here. So what do you think this patient looked like clinically?
I think they had crusted scabies if we see both of these things on one side.
Exactly. Normally in a person with scabies, they may only have like 5 or 10 mites on their whole body, and then they get post-scabetic, you know, dermatitic lesions and things like that. If you actually see a couple of 3 mites in the skin, they probably have a pretty serious disease. They probably have a lot of, they might be immunocompromised for one reason or another. So they often will have like crusted scabies. I guess we're not really calling it Norwegian scabies anymore, but basically, if you see a lot of mites, and they can have, if a patient with crusted scabies, they can have up to 1 million mites on their skin. So just make sure that you can recognize these ectoparasites. So scabies lives here. Where does the creeping eruption organism live? Like in cutaneous larva migrans, does that kind of live up in this area, or does it live somewhere else?
I think it's quite superficial, maybe a little bit under the stratum corneum, but it's very
it's kind of
superficial.
down in this area. It's in the dermis.
Okay.
So it's crawling around in your dermis, usually right around in the papillary dermis. You almost never see the organism of cutaneous larva migrans, because by the time that you take the biopsy, you're biopsying the erythematous urticarial squiggly circinate lesion it leaves behind. You biopsy that and it shows this, but you don't see the organism there. So if you biopsy a scabies papule, there's probably the burrow there, and you actually may see the mite there if you cut enough sections. But if you get a mite of, you have to actually biopsy ahead of the cutaneous larva migrans lesion if you want to actually see the organism. So you biopsy before the changes there. So if you ever want to biopsy that, try to find the advancing edge and say, I'm going to biopsy just ahead of that and see if I can get it before he's causing that allergic reaction. Where does Tunga penetrans live?
In the dermis as well.
Yeah, and it's a pretty big area down here. It forms a little apartment complex. You know, it's building a house here. It's got a little snout that sticks up to the top, and you'll actually see the little insect flight muscle, if you will, and the little. It looks like it's kind of coiled up and in a fetal position, sitting inside your dermis there. What about schistosomiasis, like swimmer's itch and those kind of things? Where do those organisms live? Avian schistosomes or jellyfish in the sea bather's eruption.
Also in the dermis?
They're up here too. They're very, very
Okay.
superficial. They don't really burrow down in your skin. So if you see them, they're kind of up in the cornified layer. What about myiasis? Where does that live?
That's in the dermis.
That's also, it forms a big tunnel also that goes down in this area here. So just know where various ectoparasites live. Some of the non-scabetic mite infestations, it's very difficult to see those actually in the cornified layer. They basically just kind of get on your skin, cause irritation. They don't live in your skin. They're not, human pathogens. And so they basically you'll get a dermatitis. It almost looks like a localized irritant dermatitis, or almost looks like atopic dermatitis. And that's when those mites like Polyarteritis get on your skin. They're not really burrowing in like scabies. This little lady is living in here, making eggs and growing in your skin. And this is if you ever get a canis, Sarcoptes scabii var canis as opposed to var humanus, those you actually won't see in the cornified layer. They're sort of like non-scabetic mites. They just kind of get on your skin, cause itching and dermatitis, and they go away. These actually are adapted to live in human beings. Okay. Good job. So let's move on to the next one here. Kind of a cool little lesion.
Good morning. I'll do this one.
Okay.
So it looks like we have a punch or an excision, and it looks neoplastic.
Good.
And I would call this benign because it's
Good.
pretty well circumscribed in that one area in the sub-Q.
Perfect.
And then when we look a little closer,
Any idea about differentiation at this power? You think it's epithelial or non-epithelial?
I would say non-epithelial differentiation.
You'd be correct. Any idea about what type of non-epithelial?
The cells, it looks like a spindle morphology.
Good. It does. You're exactly right. And so when you think of spindle, what do you think about? Sort of the three main spindle cell we see in the skin. There's four, but just the three most common ones.
Nerve, you could think about muscle, I'm blanking on others. Fibroblast.
Yeah, fibroblast and histiocytes. Good. Fibrohistiocytes. Kind of lump those together.
Yes.
Good. Those are the three most common. There are others. There's we could expand that list quite a ways if we wanted to, but we're just going to say those are the three most common. So which of the three do you think this is?
This would probably be fibroblast.
Do you think it's fibrohistiocytic?
I think so.
Okay. Let's look at this area over here at higher magnification. Is there anything about this that kind of gives you any kind of clue as to possible? What are the shape of these various cells? What's the shape of a neural spindle cell usually when we think about that?
They're more thin, I believe, compared to.
They're kind of a wavy, like
Wavy.
a sine curve, wavy S, lazy S. Think about a lazy S when you think of neural. And what about fibrohistiocytic? What are those cells more like?
Those are a little thicker, I believe.
And they're also kind of more angulated and sort of think of them more like a spiny, like spiky, if you will. That they're kind of have more of a sort of smaller, more, they're all like little tiny spikes is the way to think about those. And some of the histiocytes are a little fatter and may have sort of spiky sort of cytoplasm at the periphery. And what about a muscle cell? What do those look like?
Those are shorter, I think, in a little.
Kind of look like cigars.
Yes.
Cigar
So
shaped
these
one.
are muscle. Got it.
So, and if you cut them in cross section, they kind of look like this. They may have a little bit slightly vacuolated cytoplasm. You'll often see a periapical little clearing at the tip of a smooth muscle cell. So if you wanted to divide the side among those three, which would you favor here looking at this cell?
Muscle.
Yeah, smooth muscle probably. And so the other thing is, look at this cytoplasm over. It's kind of got that bubblegum pink color to it. Well, that's probably the actin within the individual muscle cells. And you've also got this kind of slightly bluish mucin material, which is kind of an interesting variant. You usually don't see that in smooth muscle tumors, but this variant of smooth muscle lesion that we're looking at here actually has it. And then also notice this over here. Now, this is where it kind of gets into the more sophisticated diagnosis here. You've got this vascular component at the periphery, and these cells are kind of epithelioid a little bit. So you've got both a smooth muscle or primitive smooth muscle differentiation. You've got this kind of myxoid stroma in here as well, which is probably related to that. And then you've got this vascular component to it. So this is a fairly slightly esoteric diagnosis. You probably should know what it is, especially if you rotate with pediatric dermatology.
So
Anybody have-
I thought it was a myofibroma.
Good, well, you're right. That's exactly what it is. This is a cutaneous myofibroma. They're often seen in kiddos, and they can be multiple. And it's in the family of smooth muscle, but it's myofibroblastic differentiation rather than just being classic smooth muscle differentiation. And they commonly will give you this they call it cutaneous myofibroma / pericytoma. So this change at the periphery is analogous to what you see in an hemangiopericytoma. That kind of goes along with the myofibromatous component here. So it's fairly characteristic of this lesion. And you've probably seen these in kids. They come in with usually, one or two of these, but they can sometimes be multiple. And they're often not painful. They sometimes can be, especially if they get cold, they can contract, but they're just kind of a tumor in a kid. I think it probably was a child. Then they usually clinically, they're thought to be cysts or something like that. They don't really, usually clinicians miss the diagnosis. So it's just something to realize. So this is actually pretty good for what they look like. Did you guys get that right, hopefully? Okay, good. Let's go to the next one.
I can take this one.
Okay, good.
So this looks like a punch. Epidermis looks pretty unremarkable. There's
Good.
these dilated spaces, which I think are vascular spaces with thin endothelial lining. And within that, I think there's like papillary projections.
So you think it's a neoplasm?
I thought it was more of a reactive process rather than like a neoplasm, but I would go towards that side. Yeah.
Okay. Tell me
I
what you
didn't-
mean to say reactive process.
So, well, one of the things on my differential was the intravascular papillary endothelial hyperplasia, which
Okay.
I know is like a non-neoplastic reactive process.
Okay, so you basically say a lot of people, yeah, these don't, you're right. Not every single thing can be classified as an inflammatory process or neoplastic process. That's sort of almost like a intravascular pyogenic granuloma. So it is kind of you say it's not really truly a neoplasm per se, but it's a proliferative process of cells that would probably closer to a neoplastic condition rather than an inflammatory condition. Okay, good. So you thought it was in that category.
Yeah. I don't think I see any hobnailing of the endothelium, though there are some areas where I kind of questioned it. And I don't
What's
see any.
hobnailing tell you? What does that sort of raise?
I'm sorry, can you repeat the question?
Yeah, when you say hobnailing, what are you thinking about in that situation?
Like angiolymphoid hyperplasia with eosinophilia, Dobson's tumor, retiform hemangioendothelioma.
Okay, good. So you're saying sometimes you can see vascular lesions that have these prominent endothelial cells that protrude into the lumen. And so that you see that in several different entities. Obviously, this wouldn't be angiolymphoid hyperplasia, since there's no lymphoid hyperplasia or eosinophils or anything like that. But it might be seen in one of the other vascular neoplastic / malformation conditions. Okay. Anything else that would come to mind?
I thought a targetoid hemosiderotic hemangioma, but I'm not, again, no hobnailing. I don't see any hemosiderin.
Yeah, that's the one thing when you look at lesions like this, you would want to say, well, what's the predominant thing that we're looking at here? Well, we're looking at these large ectatic spaces. They're lined by endothelial cells. Some of them are relatively prominent. So you could make a case to say these are somewhat, quote, hobnail, which means that they're actually protruding into the lumen of a relatively large size. But others are very flat and have a very thin lining to them. So they're not all these large plump endothelial cells with those kind of patterns. Here's another area up at the top. Notice how these cells are extremely thin. So when you see this, you say, well, what's the differentiation here? Is it regular blood vessel vascular differentiation like capillary, arterial, venual, or is it possibly, what's the other vascular channel we have in our skin?
You mean like lymphatic?
Yeah. That's the other one. So they could be either regular blood vessels or they could be lymphatic vessels, possibly. And if you have no red cells in them at all, it might possibly be lymphatic. And you can get lymphatic cells that sometimes have more prominent cells within them, for sure. That can happen on some occasions. If you just saw something like this, one of the things you look for when you're looking at a lymphatic is to see if there are actually any valves. So lymph vessels have valves to them. So if you see something like this, these little thin structures that are protruding like this into the lumen, those are very likely to be valves of a lymphatic structure. And you don't see that up here to the same degree, but that might be a little small valve right there. So you've mentioned a number of different entities. So, and it's good to know those entities, but you want to make sure that you can apply criteria that would obviously quickly exclude those. Like this would never be a target to a hemosiderotic hemangioma, right? Because it doesn't have any hemosiderin and extravasate erythrocytes, so that you can throw that out. It would never be angiolymphoid hyperplasia of the eosinophilia because there's no inflammation in it. So those are just, and you might look at it and say, well, it could be like a really weird, just vascular malformation that's got these sort of large, what may be endothelial cells, but it doesn't have any one single red cell in it. And it does have structures that could be valves, so that ought to make you think about the possibility of a lymphatic lesion. So that if it were a lymphatic lesion, what are the two main types of lymphatic lesions that we see in dermatology?
Like a lymphangioma.
Yeah, there's like a just a quote generic lymphangioma that's usually kind of in the deeper dermis. So this might be like a lymphangioma, just not otherwise specified, or maybe a lymphatic malformation. And then what's the other clinical pattern of lymphatic lesions that we see in dermatology?
I feel like it's probably obvious, but it's not coming to me.
Lymphangioma circumscriptum. And that's where you get like clusters of these little frog spawn-like lesions. They're little clear papules. Usually they've been present for usually a long time. Clinically, clinicians biopsy these. They think it's a poison ivy or some kind of a spongiotic dermatitis, or a bullous disease because they have these little vesicles. But they're little lymphatic blebs, and basically they're clustered, and they look almost like, and you get more verrucous hyperplasia. Most of those lymphatic structures are more superficial than this. So this would probably be, I think we just diagnosed this as a lymphatic malformation in this case. I think this came from a kid. And, there's the other one that we call so-called cystic hygroma, which is a lymphatic process. Usually those are a little deeper, and, a kid will cry and then they get bigger and they kind of have a bluish color to them sometimes. So those are the main sort of lymphatic lesions that we see. We sometimes see post-surgical lymphangiectasia, like say if somebody's had breast cancer surgery, the lymphatics will get sort of backed up, or somebody has some kind of surgery, carcinoma surgery, something like that, and they get ectatic lymphatics that's sort of proximal to where the procedure was performed. So this is just an example in this case of a lymphatic malformation we thought here. So it's just a nice example of that. And I would probably, the clinical, you very well could get a question possibly about, lymphangioma circumscriptum. Okay, good. Anybody want to give this one a go?
Hi, good morning. I can take this one.
Okay,
So,
great.
looks like we have like this excisional biopsy and have this pretty well circumscribed neoplasm in the dermis.
Okay.
At the lower power, what stands out to me the most is that there's just this abundance of mucin in this neoplasm.
Good. Do you think it was epithelial or non-epithelial?
It looked like towards the periphery, there's some areas like ductal differentiation, so I was thinking possibly epithelial.
Yeah, and well, if you just look at the cells, forget the ductal differentiation, they're kind of like that case of that hidradenocarcinoma we saw earlier, isn't it?
Yeah, pretty.
They're cuboidal. There's some clear staining cells kind of associated with it. So that should make you think again of a possibility of a follicular or possibly a sweat gland differentiation when you see that. And then if you see any ductal areas, like you pointed out, that's helpful too. But you don't have to. You know, you may not see one single duct in some of these sweat gland tumors. So that's not necessarily a criterion for diagnosis. You think it was benign or malignant?
I think it may have been a combination of both. While the overall lesion looked well circumscribed, the cells look monomorphic. I'm thinking about what the differential would be. A lot of the differentials would kind of be like a low grade, carcinoma or neoplasm.
Good. That's excellent. That's exactly right. And notice that you've got, it's not really symmetrical. I mean, you've got different size aggregations of these cells. You've got some, areas where there's some, coalescence of some of these nodular aggregations over here, but it's fairly well circumscribed. And so you can imagine if it's a carcinoma, it's going to be a low grade carcinoma. It's not going to really have a high likelihood of metastatic behavior and all. It's going to behave probably sort of like a basal cell, or maybe a low grade squamous cell carcinoma. Okay, so good. So if we think it's a sweat gland tumor, and we think it's malignant, low grade, any ideas about the diagnosis?
Top of my differential would be the mucinous carcinoma.
Okay, so tell us about mucinous carcinoma.
So
It's kind of changed a little bit in the last few years.
it's not a very common neoplasm. It's typically low grade carcinoma, slow growing. I think it most often arises on the face, particularly kind of around the periorbital area, typically in kind of older individuals. I think typically we just treat with excision with clear margins.
Right, and is there anything you have to be concerned about in the differential diagnosis of so-called mucinous carcinoma, sweat glands, mucinous carcinoma of eccrine glands?
I think the biggest thing would be making sure that it's not possibly a metastatic lesion from like a breast or like a GI cancer origin.
Good, excellent. So you've got that nailed. Now, what's been the recent development in the last, say, 7 to 10 years regarding mucinous carcinoma of the sweat glands? That if you see a classic one, what you'll see is a sea of mucin and floating within it small aggregations of cells that have eccrine or apocrine differentiation, usually eccrine, and they'll have ductal differentiation. This lesion is a little different, isn't it? It's more of a solid neoplasm here. If you took away all the mucin and just looked at low pressure, it looks a lot like a basal cell. But you've got all this, you do have the sea of mucin here, but it's not like the Pacific Ocean. It's maybe like the Mediterranean Ocean. And you've got more islands in it that are solid and nodular as opposed to these small aggregations that have the ductal differentiation. So is there a variant of mucinous carcinoma that's been described in the last 10 years or so that you can add to your differential here when you see this slightly different pattern?
Yes, it's like the really long name one. It's like the mucin-producing neuroendocrine sweat gland carcinoma.
Good, excellent. Good, that's exactly what this is. This is so-called endocrine. They call it endocrine because it's got neuroendocrine staining. So if you stain it for synaptophysin, you stain it for INSN1, you stain it for those markers, you'll get positive staining, but it's not really Merkel or anything like that. So it's just thought to have a little bit of neuroendocrine differentiation in it. So that's why it's called endocrine, mucin producing. So in other words, it's producing all this mucin. Sweat gland carcinoma, because they say this is basically sort of like probably eccrine differentiation. So it's a little bit different than a classic mucinous carcinoma for those reasons we just talked about. But basically just make sure that you understand that, because the board might ask you something about that. Say, if you wanted to diagnose this, what markers might you use to distinguish it from some other kind of neoplasms? So just understand that basically this will give you a similar staining pattern to Merkel cell. It doesn't give you the paranuclear dot pattern. It would give you a diffuse pattern with cytokeratin staining. It doesn't stain with cytokeratin 20 like a Merkel cell does, but it does stain with those other neuroendocrine markers. So that's kind of what's interesting about this lesion. And it's low grade. It does behave more like a basal cell. So that's great.
Thank you.
Good job. Okay. Anybody want to do this one? It's a great case here. This fantastic case. And this is the kind of stuff that you're going to get on the board examination. They're going to show you the most classic, obvious, beautiful biopsy lesions that money can buy.
Yeah, I'll take this one. So this looked like a punch, inflammatory process. Even on low power, you can see either a big vein or artery down in the subcutis with some inflammation around it.
Good.
It's kind of dark, maybe lymphocytes.
Excellent. Good. And you said the inflammation is around it. You tell us a little bit about how far the inflammation goes away from the blood vessel.
I think it goes pretty far away.
But it doesn't go away the heck up here, does it?
Oh yeah, not as much. Yeah, I guess it doesn't. There's a little bit like involved in the fat, but yeah, it's pretty circumscribed.
Pretty much sort of
to the
localized
vessel.
right there. That's kind of an interesting phenomenon that the inflammation targets at, and that's an important point. We'll discuss that in a moment. But so low power. What's the general pattern of inflammation here?
I would say like a deep dermatitis.
Well, okay, so here's the dermis. Left that. So now we're down in this area. So what do we call that?
So like a paniculitis.
Paniculitis. So when you're dealing with paniculitis, we've got septal and lobular, with and without vasculitis. So what would you say this would seem to fall closest into here?
Yeah, I think this one is a lobular paniculitis with vasculitis.
Excellent. And notice that it's really just almost, it's got very little lobular inflammation around it. So what are the two most common at low power here? Remember the old adage, low power diagnosis, high power mind, that Dr. Ackerman used to say all the time. What are the two diseases you think about? You can close your eyes. You don't even have to see a slide. When we say, okay, you got a lobular paniculitis with relatively large vessel involvement, what are the two diseases you think about there?
I think about like either erythema induratum or thrombophlebitis,
Yeah,
or like
or there's a third one that's sort of
polyarteritis nodosa.
Perfect. 100%. A+, gold star. Good job. So now, so we got those two, which is great. That means you just got a very small differential. We love that. That's like we say yay there. So how do you tell those two apart?
Yeah, so I think the question is if it's like a vein or an artery.
Well, let's say it's an artery. Let's say it's an artery.
Okay, so for erythema induratum, you might see like giant cells.
So let's go back a little bit lower power yet.
Okay.
So before we even look at the cells, if this is polyarteritis nodosa, is it going to involve the vessel and then lots of the fat and degeneration of the fat, or is it going to involve just primarily the vessel?
Primarily the vessel.
Good. If it's nodular vasculitis or erythema induratum, what's it going to do?
More of the fat.
Good. You get vasculitis plus lots of fat degeneration, suppurative, often suppurative granulomatous inflammation. It really destroys a lot of the fat. Whereas polyarteritis nodosa, it's sort of more directed just at the blood vessels. It sort of almost just targets it. It's like a sniper shot. It's very specific for the vessel, which is kind of interesting. I don't understand why that is. Why should you get this much inflammation on the blood vessel and spare the fat in one disease, and the other, it hits the blood vessel and causes lots of degeneration of fat? We need some smart research person to tell us the answer to that. And the other thing that's interesting is that the larger the blood vessel that's involved in PAN, the less the systemic involvement. You would think the opposite there too, right? But when you get PAN, that's got the so-called microscopic polyangiitis kind of thing, which I'm not a big fan of that term. But when you see lots of small blood vessel involvement, that's when they get the kidneys involved in the mononeuritis multiplex and the strokes and all that. It's really when they get the large blood vessels that it just tends to stay in the skin. It's almost the opposite of what you would think. So large blood vessels are lots of big blood vessels around the body, you'd think that maybe those blood vessels be evolved too, but it's not. And so this is PAN. And it's the other thing about this too, you don't have to see fibrin. Here you do have some, but when you get a larger blood vessel that's inflamed, if it's just inflammation in the wall of the blood vessel, that equals vascular inflammation. It shouldn't normally be there. Now you can get secondary vasculitis, you know, ruptured cyst, they get secondary relatively large blood vessel inflammation, and we call that a vasculitis, but it's secondary. Here it's actually primary. So here there's a immune reaction targeting this blood vessel here. And so it's a type of vasculitis. And, you know, there's some neutrophils here, there's some lymphocytes. So here's neutrophils. Sometimes you get a little bit of granulomatous inflammation in this, but generally it's more lymphocytic and neutrophilic. It's kind of like a medium-sized LCD, if you will. So it's a great case. It's a beautiful biopsy, but the key thing is to remember, just like you did, if you just get the larger blood vessel with minimal fat involvement, it's more likely to be PAN. Same blood vessel size involved with lots of fat involvement around it, and fat degeneration and inflammation within the nodules, then it's more likely to be nodular vasculitis erythema induratum, which those are two things. One thing about nodular vasculitis, you know, we just talked about that being associated with TB. It's associated with, I think the same reaction pattern occurs in reaction of leprosy when you get syphilis with vasculitis, any kind of infection that you get secondary suppuration and vasculitis of the larger blood vessels, and can give you that pattern. So it's kind of a reaction pattern. It's not confined to tuberculosis necessarily. Okay, the last one.
I'll go ahead and take this one, Dr. Cockerell.
Okay, great.
Alrighty, so we've got a punch here, and most of the action is happening kind of towards the top of the punch, towards the epidermis. I think it's more likely an inflammatory rather than a neoplastic process.
Yes, good.
And we can see there's like a little bit of crust and scaliness, and then some mild spongiosis in the dermis, as well as some cystic spaces and small blister formation.
So there's a little bit of spongiosis up here. I'll agree with that. What about this? Is this normal?
No, it's kind of tracking down like a hair follicle.
Okay, so remember, of the 9 inflammatory patterns, one pattern is folliculitis and perifolliculitis, like biliaris, alopecia areata, you know, those kind of things, alopecias, you know. So there's folliculitis and perifolliculitis. So is it possible that maybe we're dealing with a follicular-based inflammatory process?
Yes.
Okay, good. And let's take a look at it at higher magnification. Can you tell anything about what's going on in this follicle here?
Yes. So there's a little bit of red blood cell extravasation there, some acantholysis, and yes.
Very good. Excellent. Excellent. Acantholysis. Can you tell anything about these acantholytic cells here?
Yeah, they look a little bit different. The cells, they're kind of like enlarged.
Tell us about quote different. What is
They're enlarged nuclei. Yes.
Good. And there's maybe more than one nucleus inside these cells too, right?
Exactly. So
Yeah, they're hepatotic, they're diskeratotic. So what's going on here? What's the diagnosis when you see this?
I think this is most likely HSV. It could also
herpes infection.
Or herpes, yes.
Yeah, good. So excellent. So explain what's going on here with these cells.
So in herpes, we see the 3 M's, that molding, margination, and multinucleation.
I love mnemonic devices too. They really help you remember stuff. That's great. Is that if you can remember that? But what's going on down in here? What's all this business here? Is this the same thing?
This is a little different. I think this is just maybe is this the intranuclear inclusion bodies?
Well, basically what's happened is here, the herpes infection has infected the sebaceous gland also. So these are necrotic degenerated herpes virus infected cells that have wiped into the sebaceous gland. So if you want to go back to, low power, what's the most specific diagnosis you can give here? So we've got a herpes virus infection. We got that. We picked up on the side effects. We got the pathognomotic findings. It's not involving the epidermis, which is normally where we see herpes, right? So normally, zinc prep, we're going to do it up here, but we can't do that because it's in this area, right? We could do it here, but kind of hard to do zinc prep down in this area. So what do we call the diagnosis here?
Like the herpes in the sebaceous gland.
If it's folliculitis and perifolliculitis, then what do we call it? So we get bacterial folliculitis, candidal folliculitis, Cutaneous folliculitis, Miyake granuloma, and now we can get
Herpes viral.
Herpetic folliculitis. So sometimes herpes can involve the hair follicle, just like bacteria can involve the hair follicle. And if you say, well, gosh, this looks weird, I'm going to do a zinc prep over here, I'm going to biopsy this area, and you miss this, you'll miss the diagnosis. Just like if you take a biopsy from Miyake's granuloma, if you don't actually get the hair shaft that's infected, or like tinea capitis, you'll miss the diagnosis too, because the fungus just goes right down into the hair shaft. You may get a KOH up here, it's negative. PAS stain is negative here. So we don't have any herpes cells over here. They've all decided that they like the hair follicle, and they've gone down into the follicle. And that's actually sometimes seen more commonly in patients that are immunocompromised. So if you ever get back a diagnosis of herpetic folliculitis, pull back and say, well, wait a minute, is this person, got an underlying lymphoma, or the HIV positive? Is there some reason why it's attacking their hair follicles as opposed to epidermis? You can see that it's also got this follicle too. Here's the same cells over here, killing these cells here. And then you've got the nice example of them over here. So just remember that in addition to the classic forms of folliculitis, you can sometimes get some weird causes of folliculitis, herpetic folliculitis. So we thought we'd show you that one too. So that's great that you're able to pick up on that and see an example of herpes involving the sebaceous glands. Any questions about anything?
Well, thank you very much.
All right. Well, thanks, guys. And we will see you guys next time.
Thank you.
All right. So long.